leave to Belgaum, and what a wonderful group to be working with. So as long as I don't put up Dr. Hoffman's slides now, I think we'll be all set.
1 minute, sir.
No, I'll talk
Professor Derman, just permit us to quickly introduce you. Professor Derman is the current chair of the Department of Obstetrics and Gynecology, Christiana Care Health System, and director of Center for Women's and Children's Health Research of the same institution. He's a professor of obstetrics and gynecology at the Thomas Jefferson University. He is a principal investigator for research protocols of Global Research Network for Women's and Children's Health Site 08, funded by the NIH of the USA. Professor Derman has more than 60 research publications to his credit and has contributed to many chapters in reproductive health. He has been awarded as Physician of the Year, Alpha Omega Alpha, Howard University, Washington, D.C. in 2008. In 2007, he was awarded International Scholar of the Year of the International Relations Council in Kansas City. Also awarded honorary doctorate degree, First State University, Tashkent in Uzbekistan, 1995. He received certificate of commendation, Korean's Medical Women's Association, 1978, and Women's Medical Society of the Philippines, 1977. Thank you, sir.
Thank you. Even I didn't know half of that. So thank you very much. So we're going to be talking, we've reversed the order because this is a study that we have not started yet, but we're going to be starting. But I want to sort of build up to the story because we're trying to, with this global network, the idea came 15 years ago at the Gates Foundation and NIH that maybe we needed to address the leading causes of death in women and neonates especially. And it was nice that funding took place, and it was particularly nice that I was at Illinois then, and we had our colleagues from Belgaum doing work with us, and we wrote the grant together. And we were very fortunate to go ahead and get that grant. But before I go on to the evolution, let me just go ahead and bring you welcome from Christiana Care. This is one of our 2 campuses. And I show this because actually I'm moving on in about 3 weeks to the parent institution of Christiana Care, the academic institution, which is the big city of Philadelphia, Thomas Jefferson University, where I'll be involved and be able to spend full time in global health initiatives. So I'm very excited about that and sort of look forward to it and continuing to work with my colleagues, Dr. Hoffman and the rest of our group. You know, there was a very famous bank robber in the United States. His name was Willie Sutton, and they finally caught up with him. And they said to Willie, they said, you know, why do you rob banks? And he said, it's because where the money is. That's where the money is. Well, if we're going to go ahead and change public health and impact and the leading causes of death in women and babies, we have to go where it's going to do the most good. So we go ahead and we look at things like postpartum hemorrhage, we look at eclampsia and preeclampsia, infections, maybe perhaps unsafe abortion, and if we go ahead and address these issues, then we can probably have an impact on 80% of the mortality. This is a big deal. And so when we began these initiatives, actually, postpartum hemorrhage was #1 in the United States, but there's a word of caution. Because if we take a look at the US data, and all of us who lecture in global health like to compare ourselves to the country that we work in, this is now #5 in the US. And obesity, getting married at an older age and having children at an older age, diabetes and chronic disease has crept in. And this is a major scourge all around the world, and we're going to see it in India as well, which is one of the diabetes capitals of the world. And you can see that 2 of the 4 leading causes of death in the US actually relate to the heart. Very, very different. So we have to stay tuned, and we have to be aware and very vigilant to these changes. Well, when we wrote our initial grant, we didn't think it would be funded. It was a very simple idea. Let's take misoprostol. We knew it was not only an abortifacient, but we knew it was a uterotonic, a strong uterotonic. And nobody had done a randomized placebo-controlled trial at that point. And so we said, let's do that, and let's see if we can get a 50% reduction in the rate of postpartum hemorrhage. And defined, perhaps inappropriately, as 500 mLs of blood loss. And indeed, we saw a 7% reduction. in our primary outcome, and an 80% reduction in those women who will likely get into trouble, those bleeding more than 1,000 mLs. I think even more important from a public health perspective is the number needed to treat. And we showed that 1 case of postpartum hemorrhage could be prevented for every 18 women who receive misoprostol. So that doesn't necessarily translate into those women always getting into trouble, but nonetheless, it was an important finding. And that paper in The Lancet generated lots of controversy around the world, and with thousands of hits. And I think more importantly, it led to other groups getting on board and duplicating our study. In Pakistan, the Ganuity group did that, and actually 4 studies where women were given the misoprostol themselves, and we showed no untoward outcomes in those studies. And if one goes to Africa, one can often see trucks like this, thanks to the work of Metin and others who've allowed misoprostol to be an essential medicine list of the World Health Organization. So that's important. So we move from postpartum hemorrhage into the area of eclampsia and preeclampsia. And you're going to be hearing more of this in our next session, and I think Dr. Van Dedelzijn will be here tomorrow to speak about the CLIP trial. But suffice it to say, this is, again, a community-based package of care. And the idea was to improve maternal and neonatal outcomes, and it addressed the 3 main delays of care. And where it was appropriate, actually treatment was initiated in the community. And just this week, we had a small group working on a sepsis proposal that we just submitted, hopefully for funding, which looks at the postpartum period. Even though WHO says, let's get the mothers to deliver in facilities, when they finally develop postpartum sepsis, it's usually 2 or 3 or 4 days later, and they're back in the village, and often they think that these signs and symptoms may be normal. And by the time they're diagnosed, it's often too late. So the concept is to predicate it upon a bundle of simple interventions with point-of-care monitoring, looking at the positive predictive value of this, and indeed, if it turns out to be positive, we may be able to move on to a much larger study. So moving from the mother to the baby, we ask ourselves, why do babies die? And we know that post-neonatal period, about 50% of those conditions are preventable by immunization, by oxygen, by antibiotics. But in the neonatal period, we don't have that ability, nor are we, just like in postpartum hemorrhage, nor are we able to predict who is going to go ahead and have this condition. We certainly probably 10, 20, 25% know who the high-risk women are, but in terms of those who end up having it, often these are nulliparous patients. So what we wanted to was initially begin to focus in areas like asphyxia, and we did that with our training, and this was training for newborn care. This was a New England Journal of Medicine article that was published showing that we were able to prevent and reduce perinatal mortality in the developing countries. You heard about the ACT trial, and I won't duplicate what we just heard. Suffice it to say that for every 1,000 women exposed, in excess of 3.5 neonatal deaths occurred with an increase in maternal infection. So obviously, we need to look into this a bit more. And so when we take a look worldwide at what we're doing to try to prevent preterm birth, either from a primary or secondary prevention, a few things come to mind. The age of marriage comes to mind. And even though India has an age of marriage with 40% getting married under age 43, they've moved dramatically. It used to be much, much worse. Some of the countries in Africa have not done as well. In India, there really is no child spacing. People have their 2 or 3 children and have a tubal ligation generally. So child spacing, we know, may affect preterm birth rates. In terms of looking at how to maximize and reduce preterm birth rate, it's often been said that the state of a woman's health when she enters pregnancy is the best predictor of the outcome. And so how do we maximize health before people become pregnant? So what about an ideal BMI? Maintaining glucose levels, looking at hypertension, perhaps anemia, infestation and nutrition. These all need to be looked at. You heard from Dr. Hoffman, or you will hear from Dr. Hoffman, assuming your slides get loaded, that we may need to address lower tract infection. This may not only be V that he's going to be talking about, but maybe even urosepsis, where we have lots of data in the developed world, but very little in lower resource countries. You also see a lot of articles on the use of progestin and cerclage and pessaries for short cervix. But this is not going to have the major impact we want on a public health basis. And so we turn to the use of low-dose aspirin. And I'm not going to go through all of the issues that you've heard from the other speakers in why we need to address preterm birth. Suffice it to say, it's the leading cause of death in under 5 babies, and certainly half of the deaths occur in the first 24 hours of life. In neonatal death, 75% in the first week. Most of these are due to preterm birth. A good number, asphyxia, are related to preterm birth as well. And in India, 309,000 babies die on the first day of birth. So we've been able to go ahead and decline the under 5 birth rate, but we have not had the same slope in reducing neonatal mortality. You've seen this slide, but you haven't seen it in terms of preterm birth rate. And the only thing that I would share with you is dark blue, and blue is not good. And if you look, the United States is included in this graph as well. We do very, very poorly in this arena, and we're trying to figure out why that is the case. The cost of preterm birth, this is just US data, $24 billion, third leading healthcare cost of anything that we fund in the United States. We can ill afford it in the US, we certainly cannot afford it in the developing world. So we need to address this issue very importantly. Why is the range of preterm birth 5 to 18%? That's a dramatic range. So do we have bad reporting, or is the range really this severe? This is just showing the data of the US in yellow. This is the state of Delaware, where I live, showing rates only 2% less than that in India. We also know that the earlier one delivers, the poorer the outcome. And so obviously, if you have a NICU, these babies stay there for many, many days with a very, very high cost. So the idea is to go ahead and get infants, even if they're going to deliver preterm, to deliver closer to 37 weeks than to 34 weeks, because the costs are enormous, and the social cost to the family in terms of neurologic disabilities is just terrible. So I was privileged to go ahead and present this protocol that was developed by a group of folks, including Dr. Hoffman, at the 15th anniversary of the NICHD meeting, honoring our 15 years of doing research together. And basically, aspirin is the acronym for aspirin supplementation for pregnancy-indicated risk reduction, and here's the keyword, nulliparous. So maybe it's a surrogate marker for preeclampsia, but perhaps not. If we take a look at WHO data, and we look at the countries that we're going to be working in, we're really looking at almost 5 million preterm births in these countries, and every country is going to be part of this study, with deaths approaching 450,000 and an overall total of 13.1% in preterm birth rate, going from a high in Pakistan of 15.8% to a low in Guatemala of 7.7%. So there is always a concern when you go to the regulatory agencies about why aspirin isn't it dangerous. Aren't we going to do terrible things? It was used in pregnancy by Aristotle, 400 BC. There's at least 50 million doses that have been given. It was manufactured by Bayer in Germany in 1897. Without question, it's the most widely used over-the-counter medication worldwide. But perhaps more importantly, 57 clinical trials of aspirin have been used in pregnancy. 51% with aspirin alone. It involves over 32,000 women, both women who are high risk for high risk for preeclampsia and for preterm birth, and the general population. The two largest studies, the CLASP study, if you took a look at the mean number of weeks when patients were recruited into the study, 19.4 weeks. The MMFU study, over 20 weeks. So the most recent trial to be published was the EAGER trial. Now, this was a trial that didn't look primarily at preterm birth. It actually looked at women who had pregnancy losses to determine whether aspirin would enable them to have a live birth. And while it did not reach statistical significance, a number of things were important about this study. They started very early, preconceptually, and they noticed in the predetermined but post hoc analysis that the preterm birth rate in the first segment of women who only had one pregnancy loss, ostensibly similar to the population that we want to be testing, had a relative risk of 0.45. So then we turned to all of the meta-analyses that have been published. Roberge did a meta-analysis that showed of all of the studies, there was a reduction in preterm birth of about 19%, a relative risk of 0.81. The U.S. Preventive Task Force now suggests that low-dose aspirin, they say 81 milligrams because that's what's used in the U.S., be used on all patients at high risk for preeclampsia and SGF babies as well. And there's only one meta-analysis where we looked at those who were recruited into studies before 16 weeks. And fewer than 1,000 patients in 6 studies are involved in that. But yet the relative risk was 0.35. So a compelling story to take a look at why we should go ahead and do this and why we shouldn't be biased by people who may be having multiple interventions if they're already at risk, and looking at an nulliparous population who are already considered at increased risk, both for preeclampsia and for preterm birth. So in terms of the U.S. Preventive Services Task Force, I mentioned this. In the U.S., preeclampsia accounts for 15% of preterm birth. I think in under-resourced countries, it's much higher than that. But most importantly, there was no safety signal seen with the use of aspirin in any of these trials. So this tree is supposed to represent the placenta. There's good biologic plausibility of intervening early before the inflammatory cascade can begin while cells are dividing quickly. I think that this would be...
1 minute left.
Thank you. That this would be an important time to go ahead and do this. We want to increase blood flow and prevent platelet aggregation. We're going to begin between 6 and 0.7 weeks through 12 and 6/7, and we're going to, this will be an individually randomized clinical trial. We're going to look not only in reduction in preterm birth, but the secondary outcomes, because this is such a large study, are going to be equally important as well. So stay tuned for that. As I said, individually randomized. I gave you the dates, and everybody will take the study medication or an identical placebo up until 36 and 0.7 weeks. So we perhaps we're underpowered, overpowered, because we used a rate of 8%. We know the preterm birth rate in the countries we're working on are a lot greater than that, but the total sample size is almost 12,000, 11,920, and to show a 20% reduction from the usual rate of preterm birth. These are the numbers by site that need to be recruited. Notice that the Belgium site has the highest number. This is the time frame. We're already a year. All of the training has occurred except in Guatemala, and we're about ready to start in the 3 African sites within the next month or 2. Future state, well, we already heard that we've done work preconceptually. We've done the ultrasound study. We have a very robust registry. We have diverse populations. We realize that in order to be rejected or accepted as standard of care, we need this very large trial to be done. Everybody knows what baby aspirin looks like. We usually see it in treating cardiovascular disease for men or prevention of thrombotic stroke in women. This is the package of 2 weeks that are going to be transferred out every 2 weeks by the health workers. This is an Android that we're going to be utilizing to help us select eligibility, determine EDD, and the trial is important because it's going to be the largest trial to examine low-dose aspirin and use a dosing time frame that in fact makes good biological sense. The cost will be very inexpensive, about $2 compared to the massive cost in terms of NICU care. However, we still have our problems, and we still have them in India. We still do not have our approval to conduct this trial. This is the last country where we haven't received approval. There are diverse regulatory directives, multiple agency approvals. There doesn't seem to be a distinction between academic research and pharmaceutical industry trials. We've addressed the informed consent issues. We've addressed good manufacturing practices and picked a manufacturer in India to make this. We've convinced everybody that one doesn't need a new drug application. We're going to maintain bioavailability and stability data. And stay tuned. Hopefully in 3 years, we'll all be together and we can share this data. So thank you very much.